Hi, he is a 52-year-old gentleman who has undergone radial keratotomy about 30 years back, and now he's come for cataract surgery of this eye. He's got pathological myopia in both the eyes, and this eye is the Verser eye. He also happens to have a macular pathology, so the visual prognosis is of course a little guarded in this patient. Now, planning a cataract surgery in eyes who undergone previous refractive surgery, especially refractive radial keratotomy, is a challenge. The concerns in this case would be twofold. Number one would be to get the intraocular lens power calculation right, and number two, to deal with the intraoperative challenges. For IOL power calculation, I'm going to rely on the Barrett's-Truquet formula and then compare it with the online calculator at the ASCRS website, and then probably take an average. The patient underwent optical biometry through IOL Master 700, and these are the reports, and then we compared it with the online calculator at the ASRCS website, and we aimed for a target refraction of anywhere between minus 0.75 to 1 diopter. Aiming for a target refraction with slight myopia is usually the best strategy, which has helped me when dealing with these post-RK eyes. We also did an specular microscopy of this patient, and patient did show a slightly lower level of endothelial cell counts, and this also had to be taken in account when I'm performing the surgery. That is to ensure that the turbulence inside the chamber is minimal so that the endothelium can be protected. Now, moving on to surgery. Surgery is being performed under topical anesthesia. The patient is quite comfortable and relaxed. And the major concern or the intraoperative challenge is I need to ensure that these cuts don't give way. There has been multiple reports that these cuts can give way during the surgery. So I am planning such a way that I don't have that intraoperative complication. So this is an 8-cut RK. To plan my incisions, I have got sufficient space. I'm using this inked dialer to mark out the areas of incision. So these are the two side ports, and this is the place where I'm going to have my main incision. Care is taken that these incisions are positioned exactly in between two cuts. So begin by surgery by creating two side port incisions. Air is introduced into the eye, followed by intracameral lignocaine, and then trypan blue is used to stain the entercapsule. The pupil is not extremely well dilating, but it should suffice. Chamber is pressurized with OVD and time to perform the main incision. In eyes who have undergone radial keratotomy, my preference is always to perform a sclerocorneal tunnel in between two cuts. I have created a scleral groove, and then using a 2.8 mm, I am going to create a sclerocorneal tunnel entry into the antechamber. The capsule is punctured with bent 26 number needle, and then using Rexis forceps, the flap is held and the Rexis tear is initiated. So I'm planning to have a 5 mm Rexis. An appropriately sized and centered Rexis is created. Time to perform the hydrodissection. I'm going to decompress the antechamber by burping out a little bit of OVD before placing my cannula just under the antecapsule, and using a small amount of fluid, cortical cleaving hydrodissection is performed. The nucleus is then decompressed from the other end. The nucleus rotation is confirmed. The nucleus is slightly on the softer side, and the strategy which I am going to use for emulsifying will be like this. So the fundamental principle I'm going to use in this case is to use a low infusion pressure. I don't want the intraocular pressure to be high, which can result in these cuts getting compromised and some of them can open off. So I'm planning a low pressure surgery. So the only thing which I'm going to do is bring down the bottle height to about 50 to 60 centimeters from the usual 90 centimeter which I'll be operating. And to compensate for that, I also will be reducing the flow rate in the vacuum to ensure that the chamber is maintained well. And this philosophy is going to be utilized in all steps of phacoemulsification. The superficial epinucleus and the cortex is being aspirated out, followed by beginning the trench. I plan to do a stop and chop technique in this case. So these are my sculpt settings with a relatively low bottle height and a high phaco energy. Once I create a long and a thin trench which is about 60 to 70% depth, I'm going to divide this nucleus into two heminucleus by placing the sharper as well as the phaco tip deep inside the groove, and the lateral separation maneuver gives us two heminucleus. The nucleus is quite soft and chopping them is going to be a challenge. So I change my settings to the chop mode where I'm going to use only the longitudinal energy. The power is set at just 10% and still I'm finding it difficult to grip the nucleus. Nevertheless, the nucleus could be divided into two halves, and using the same longitudinal energy with very low power, I'm going to engage one of the fragments and pull it out of the bag. And now I'm going to shift to quadrilateral mode where I'm going to use the torsional energy to emulsify it. Again, the care is to be taken that a very low energy is being utilized. So the first heminucleus is emulsified out. Time to deal with the second heminucleus. The chamber is refilled with viscoelastic. The nucleus is rotated so that it becomes more accessible. One can see that it's difficult to engage the nucleus because of its softness. Nevertheless, using extremely low power, I could just get hold of the nucleus, pull it out of the bag, and it was chopped to divide into two smaller fragments. Time to emulsify each of these fragments. Again, I'm going to use the torsional energy to do the same. Soft cataracts are a challenge and you need to have the right strategies to deal with it. Dealing with these fragments is easy. Getting the initial chop and pulling them out of the bag can be tricky sometimes. So, time to remove the cortex. Again, this principle of low pressure surgery is being followed here. Again, the bottle height is maintained slightly lower than what usually I do. And again, to compensate for that, I'll be reducing my flow rate in vacuum just to ensure that the chamber stability is not compromised. The posterior capsule is flushed with BSS just to clean up any of the small remaining fibers. The capsular bag and antechamber is filled with OVD. A time to implant the lens. The planned single-piece hydrophobic lens with appropriate power is being implanted into the bag. OVD both in front and behind the lens is aspirated out. Time to close. The stromal hydration is done gently, as is the main incision. So these are the post-op pictures of the patient, and these are the post-op refraction after 15 days of surgery. The spherical error is not significant, but there is significant amount of astigmatism. That is because of the cornea, which is, to summarize, we're performing cataract surgery in an eye who has undergone radial keratotomy previously. Getting the power of the intraocular lens right is going to be a challenge, and then we need to modify our surgical technique in a certain way to ensure that we don't have any intraoperative surprises. So I would prefer to perform a low pressure surgery in eyes who have undergone radial keratotomy. This helps in preventing these cuts from opening up. It's also important to plan our incisions in such a way that they are exactly in between these two cut areas. And of course, the other precautions which we take for any routine surgeries, I like to ensure that the corneal endothelium is protected, has to be carried out in this case as well. That was it. Thank you for watching and hope you found this helpful.